And here we go. Part 3, HLA. So this is where we're just going to go through processing, storage, and all that stuff of cord blood. Oh, and it's the rest of it. So the cord blood, probably the best thing about it is that it used to be considered waste, right? We used to just get rid of it. But now, because we realize that there actually are a fairly good number of HPC in this specimen, and at the same time, there are a lot less antigens that are expressed. So we can get HPCs that express less antigens. That allowed the medical community to really consider this as an option. And it was in 1988 that the first human umbilical cord blood transplant was done. It was in October of 1988. The patient it was a pediatric patient, had Fanconi's anemia, and to this day, patient's fine. Patient continues to be healthy and in complete hematologic and immunologic reconstitution. That's great. Okay. These are particularly attractive for those pediatric patients and adult patients who really we can't find an HLA donor for. Because the umbilical cord blood contains, it does contain these hematopoietic stem cells, they have found that the stem cells in umbilical cord actually seem to have higher proliferative and self-renewal capacity. Between that and the lack of other antigens, there is a decreased incidence of graft versus host disease, particularly of the acute variety. But there is an overall reduction in graft versus host in cord. That's something that has to be considered because remember, the chronic has the benefit of the tumor, of the graft versus tumor. So this is difficult to consider. Okay, you have a lot to consider is probably the best way to say it. So now at this point they have developed cord blood banks. They have private and public cord blood banks, and there have been allegedly over 250,000 units, unrelated units, banked worldwide. So that doesn't include the private bank. So what a private bank does is I collect the cord blood off of my kid and I maintain it for my kid for his, or our use, I should say. Okay, it's the unrelated units that are banked worldwide. Okay, now there is some question about ethics. There is, you can see here that allegedly we say there's no ethical problems with collecting the cord blood, and probably what they're referring to there is the issue of collecting cord blood from aborted fetuses, because there is an ethical problem there. But there are ethical things to consider, and the biggest one probably is the fact that the mother is making all these decisions, but the blood doesn't actually belong to the mother. It belongs to the baby and not the mom. And then you also have the ethical issue of public versus private banks. That's kind of a question, right? So does that mean that only the rich can afford to have this? And I mean, it's not crazy. I don't think it's crazy expensive. I don't remember, but because I got some of this material when my kid was born. But if this is not equally available to all, that's one of the tenets of medical ethics, that it really does have to be equally available. And it's kind of if you're talking about private banks and all that stuff, it's not really equal. So probably the stickiest part of this whole cord blood issue are the consents. So the patient, and this would be the mother. The mother has to be educated. Many of the people in this business consider it easier to get the blood from the cord and the placenta, and many people who say, well, it's going to go in the garbage anyway, let's just get it. Okay, but we still need a consent. You can't just take it, okay, because it doesn't belong to you. All right. And so they're saying, you can't say, well, it's just going to go in the garbage. I feel like I should take it. There is very little or no discomfort to the mother. Certainly, there's very little or no inconvenience. And if we can educate physicians, staff, and the OB community at large, they might be able to recruit patients into the program. The question then becomes, though, wait a minute, do I have to put this in a public bank and it might be used by somebody else besides my kid? People question that. Well, then you have to use a private bank. There are, however, AABB in advance of this, they have put out what are the things that you have to have, what's the minimal information that you have to have on your consent form, so that everybody knows what everybody else is talking about. And the AABB requires that you include the name of the bank, so it can't just sort of be ubiquitous, I don't know where this is going to go, the name of the bank that it's going to go to, the organization that owns the bank has to be listed there, and the medical uses of the cord blood once it's collected. So is it going to be for you, for, who's it going to be for? And patients also have to know that this isn't something that can cure everything. Your patient has, if your baby has a heart attack, this isn't going to help it. Okay, so they have to understand that as well. They also have to explain how much experience, how long they've been doing this, and a brief description of the process itself. The risks to the mother and the fetus have to be explained, and any tests that are going to be done on either the cord blood and or the mother have to be explained and signed off on by the mother. And then, are there any costs? In a private bank, there are costs. In a public bank, there usually aren't any costs. You just submit the unit. Again, reiterating, the patient has to know who is this going to be available to. Now, if it says, and it has to be pretty clear. So it might say, you might say, well, I'll put it in a public bank because then it doesn't cost anything. And who else is going to match it? But then your second cousin has an issue and they need it and they come and they take it. So you have to be aware that this is, available, if it is available to the public. And some of the other things are requirements on us, like who are we targeting with this? We really need to get the various ethnic groups that are affected by this. If you have information in a OB delivery room in a Black neighborhood where you're going to get essentially all the same kinds of cord bloods, but that the need for these, maybe it's the Hispanic communities that are having the most percentage of the particular disease you're trying to target, whether it's an autoimmune or a cancer. You got to try and sort of spread out the information, because getting it from just one ethnic group, it is going to limit your genetic variability in your bank. Okay, but that's the role of the bank, not the patient. Okay. All this information has to be available not only when consent is given before the birth, but also at the birth, because the mother can rescind that consent at any time, even at the last minute. And all that testing that we do normally on these units, that's all going to be done on the mother beforehand. Okay. That way we know. That we will do type and cross on the unit. That once we get it. But the infectious disease and those risk tests are going to be done on the mother. And there are some other rules. any consent, because now this consent can be given right up to the last minute. Even it could technically be given almost after, but there are rules. You cannot do this. You cannot get consent while the mother is actually in active labor. Okay, that's rude. Plus, she's not really in her right mind, so leave her alone. So it has to be, we have prenatal consents, so before labor has ever begun, intra-labor, so during labor, but not during active. So the mother is in the hospital and she's started labor, but the contractions are still 2 minutes apart, and so you have time between contractions to get that consent, but not during active labor where the mother is actually pushing, that quickly. Okay, that's not allowed. And it has to be, this is usually, by the way, done by the staff of the bank. Okay, most hospitals don't have a bank, so it'll be done by the staff of the bank. Have to have the mother's signature, has to be a witness, has to have the date. Okay. There does have to be, if it's an intra-labor consent, there does have to be a second judgment or an area where the doctor can say that this was done. It could be the OB staff, any of the OB staff, nurse, whatever. They basically can say, oh yeah, she's able to talk about this. She's not crazy in pain, okay, or anything like that. So there has to be that extra place that the doctor said. If this was done during labor, then yes, she was paying attention. She knows what's going on. Then you have post-delivery consent and collection. This would literally have to be very quickly after, because the collection has to be done fairly quickly after delivery. So again, that's up to the staff. How bold do you feel? And overall, the ideal one is multi-phase. So you approach the mom at the prenatal time before the labor becomes an issue. During labor, you remind her this is what you wanted to do. Is this still what you want to do? If she continues to say yes, you begin collection. And so you really do want, if you can get a multi-phase consent, that's the best mechanism to do it. There is a protocol for an abbreviated consent, where sort of it's like, the mom's screaming, yeah, fine, do it. In that case, you can do collection only, but everything else has to wait until you get a full and well thought out consent done when the woman is back and in her right mind. And because then you're going to have to go through all this stuff again, okay? Okay. Now, there are places that disagree with some of the types of consent. Like there are places, the American Academy of Pediatrics, they don't like the post-delivery in the sense that they don't, or I should say, they want to, what's the word I'm looking for? They want to discourage post-delivery. But if you can do it within 48 hours of collection, they'll accept it. It's all, everybody wants to get their 2 cents in. The ideal is to get a multi-phase consent. Now, the medical evaluation and donor testing. Remember, this is all on the mom, okay? But we have to make sure that collecting this will be safe, and it will be helpful, and it will be useful, okay? So, for example, how do we know if this will be useful? What's the clinical efficacy of this? Well, there are some things that will affect how useful it's going to be. How many pregnancies has this woman had? How old is she? The birth weight of the baby and the APGAR score of the baby. Those are all going to come into play in determining how good a unit this particular cord unit would be. Okay, so you measure the clinical efficacy overall by the number of cells. So the unit is collected, how many CD34 positive cells do we have in that unit? That's the easy way to measure it. And the higher number of cells, you know, we usually have more cells the women who are earlier on in their pregnancy history, right? They're their first or their second. We usually have more cells. What's the reason for that? Well, that's completely beyond me. But the fewer previous pregnancies, the better the unit that we get. Also, by age here, not just the age of the mother, because that is going to be an issue as well, but also the gestational age. You can't do it from the overdue babies are, you get a much lower quality product from those. So if baby's gone past week 40, generally speaking, we don't get a good unit. Now, most doctors really don't you can only go 2 weeks past it anyway, so that's why it's a very tight calendar. Most doctors will start thinking about taking it. If you go past 2 weeks, the rate of fetal death is very high, so they're not gonna let you go past 2 weeks usually anyway. If the birth weight of the baby is way off, and actually you might think, oh, well, if it's too small. Obviously, if it's too small, that's unhealthy. That's not safe to be in there bothering the mother and the baby. Still possible, but small, you're going to get very little product, okay? Because if the baby's small, so also is the placenta, okay? The issue really is, how big is this sucker? Okay, a baby that's greater than 2,500 grams, that's a pretty big baby. Those babies actually have lower quality products that we can get from them. The birth weight of the baby is tied tightly to the health of the mother, and the biggest babies come from diabetic mothers. And so those babies are going through a lot of stress throughout the pregnancy, and part of it is actually their size. They're these huge babies. Okay, so that's also something to consider. And then the APGAR score. So maybe you've never heard of an APGAR score before, but this is a score that the physicians and the nurses use to sort of they want to give a number to how healthy the baby looks, and they assess the baby on, and I don't remember what did I write it down? I forget what APGAR stands for, but it has to do, I know their skin color, their respirations, their movements, things like that. Those are all taken into account, and they do it at several intervals. And so they want a 5-minute APGAR score at greater than 8. So that's a good APGAR score. Okay, most preemies will not have an APGAR score that's that good. So the little babies, the little small babies, usually have kind of bad APGAR scores. Okay. Obviously, you don't want a situation where they're resuscitating the baby over here and I'm collecting the cord blood over there. Tacky is the word that jumps directly to mind, but also unethical, okay? And then, of course, if the baby has any signs of birth defect or infection, then it's not a good idea to take the cord blood. Infection is obvious, it'll be infected, but also birth defects. You don't know what genetic things you're moving on to your patient. Birth defects are genetically, usually, there are some developmental ones, but they're usually genetically determined. And so stem cells are all about genetics. We don't want to pass on, we don't want to give to our patient something that's genetically flawed. And we don't have much time to make a decision. We have to decide right then. So if there is a birth defect, then okay, no, not taking that unit. Is the birth defect always immediately obvious? No, and so those things might come up later, but you have to make a decision right now. Okay, that's the time that you have. As far as safety goes, part of this will come from the screening of the mom. Are there any genetic or transmissible diseases that are present? Then for safety, then we wouldn't obviously use those units. These are all the similar tests that we do on any unit that comes out of the blood bank. Okay, similar infectious disease testing. And the methods for doing it are the exact same. We don't really do different ones because we do it off of a peripheral blood from the mom. Okay, so there is something we have to take into account, especially with the genetic end of the diseases. We're testing mom, but we don't necessarily have a lot of information from dad. Is it possible to test both of them? Yeah, it's possible. And that, you know, you can definitely do that. And while AABB doesn't require that you test the father, certainly you can ask some questions and things that would make sense, you know, or is the father a werewolf? I don't know. You could ask some crazy questions. Those would certainly be advisable. Okay, you can always add better questions. And you definitely want a full health history from that mom. If the mom is not willing to give a full health history, you can get this if you're doing the prenatal. You can probably get this before birth. But in some cases, especially if the consent was given close to the time of delivery, then you can wait until after birth to take the health history, but you can't wait more than 7 days after delivery, okay? We shouldn't be collecting a history. The idea being, do I really want to take a full health history off of a woman that I might not actually get the cord blood on? So some places say, okay, you know what, we'll get the consent, but the history we'll get afterwards. We don't need it right now, okay? And if you did get a history, and that's fine in the prenatal period, you have to update it after within 48 hours of delivery. Okay. In Europe, there are some rules about recollecting or recontacting donor families before issuing the unit, just to make sure that they're reassessing that health history, but we don't have that requirement in the U.S. Okay. And then the donor testing that we do over here, it's similar to whole blood testing, well, except that it's done on the mother, right? It's done on a surrogate and not on the actual donor. So what we're following here is the disease that any disease that the infant has likely came from the mom. Okay, so that's the theory anyway. And of course, you would need her consent, her specific consent for those tests. You can't say that it's on the unit. You're taking blood to test her in lieu of her baby. And then there's only one other thing that we do that obviously we don't do this necessarily on the whole blood units, and that's screen for hemoglobin variants. While it doesn't, if you have a variant, it doesn't necessarily disqualify you. We definitely want to know if there is a variant in there, and then some banks will store those specifically. So if you know that you have a sickle, a unit from a sickle patient or something like that, they'll store those specifically for when a patient who has sickle, if and when a patient who has sickle needs those units. The collection. So these collection bags, they actually have a product, a collection bag that's been produced. It can hold 150 to 250 milliliters. It's a bag. It looks just like any other blood unit bag. Anticoagulant's the same, ACD or CPD. It's the same. And the kit manufacturer will include the correct amount of anticoagulant. So for example, in the 250 ml bag, you have 35 milliliters of anticoagulant. So it's the correct amount of anticoagulant for the size of the bag that you're going to use. Okay, and then it comes with a needle and the tubing. It comes all in a little box and everything for you to have ready at the time of the collection. And there's two different mechanisms of collection. We have in utero collection and we have ex utero collection. So the procedure is actually the same in both of them, but well, it's a little different. The idea is you're going to identify the umbilical vein. So this is the child has been delivered, the umbilical cord cut, and the placenta is still attached to the mom. She has not delivered the placenta yet. That comes a few minutes later. The bank nurse, the cord bank nurse will step in to the patient after the doctor is finished, identify the umbilical vein, clean the site, and then you're going to clean it with isopropanol. You're going to also scrub the site with a broad spectrum topical microbiocide. Remember, this is not sterile, so you want to scrub it for about 30 seconds. You're going to place a hemostat on the tubing, a few of the tubing of the bag, a few inches from the needle, and then you're going to access the vein. So you've got you're sort of blocking off that vacuum that's in the bag with the hemostat. After you access the vein and you know you're in the vein, then you release the hemostat and the blood will flow into the bag. And the nurse will gently mix the bag to make sure that it mixes well with the anticoagulant. The cord will actually collapse when the collection is complete. In particular, if it's an ex utero collection. If it's still attached, you'll be able to get more product. Okay. And the way to monitor the volume is by weight, and you're going to have a scale there so that you can make sure you know how much is in that bag. Then, once the collection is complete, you're going to hemostat the unit, the tubing again, high up. You're going to remove the needle and get rid of the needle and allow the woman her privacy back. But then that blood that's in the unit, you're going to strip that tubing to make sure that the blood from the tubing goes into the unit. You want every last drop to go down into the bag, okay? So the collection methods are actually the same, right? The procedure itself is actually the same. The difference really is, where is the placenta? If you have the opportunity to do it when the placenta is still attached to the mother, it actually you kind of get better flow, right? Because you have gravity and you have the circulation of the mother helping out with that. However, if the condition of the mother or the child is in question at all, then it's not done. Also, in some hospitals, they say, we're not doing it in utero. That's just not the way we're going to do it. It's too invasive, invasive is not the right word. It's too impolite. You know, it does not maintain the privacy of the mother the way they want to. So then in those cases, we can do ex utero. There are benefits to ex utero. The fact that the staff who needs to collect it are totally off to the side and they're not in anybody's way in case anything happens, that's a pretty big thing. Pardon me. It's also, pardon me, pretty simple. A lot of times they just train the nursing staff to do this on the side, and you don't need to necessarily get a bank person in that's separate. But in the utero, what they do is they do the same procedure. The placenta is out. They actually have a stand that you can put the placenta in to hold it up higher than the bag, and you're going to get it's a gravity device, and then the procedure continues the same. So the placenta is held up in this gravity device with the cord passing through this little hole in the bottom, and so you get the same kind of position as you would in if it was still in utero. What's a benefit here is that I can actually manipulate the placenta. It's called milking the placenta, whereas I can try and force out more blood if I'm not getting enough out of the umbilical vein. There is going to be an increased rate of contamination if you in any way manipulate the placenta, but it's something that can be done. Now, processing is also different in the cord blood, because while it doesn't have necessarily all the junk that might come out, the fat cells and all that stuff from a bone marrow, pardon me, it's got more stuff than an apheresis. Okay, you definitely have red cells. Okay, so processing here, there's a whole bunch of different steps where you're going to be removing the excess red blood cells and plasma to bring each collection down to a single unit volume of around 20 milliliters. So 150 to 250 down to 20 milliliters. It's a very small unit, okay? And then that, and if you have a collection, a really big collection, maybe, I don't know, really large, a good size placenta, you can actually just put it in 2 separate bags. We don't make it a larger unit. All cord blood units are 20 milliliters. Okay, and that allows uniform freezing and uniform conditions for storage. So you get a lot better, and most storage in cord banks is automated. So if everything's the same size, it's much easier to make sure that standardization happens if everything's the same size. So the procedure that occurs once it arrives in the laboratory, they're going to be logged in and weighed so that they can verify the volume. And then the cord blood will be transferred using a sterile docking device from the collection bag into a sterile disposable processing bag, so that preparation can happen. Again, most cord blood banks, it's automated. So they have, it's called an Auto Express or AXP platform that was approved by the FDA for this purpose since 2006. Okay. They will remove some samples from that bag. If you look over here, you take a few vials off and you're going to do your QC on the bag from that. You're going to need to do a total nucleated cell count, a CD34 positive cell count. You're going to have to do, and you can also do infectious disease testing on it if necessary. Then the samples, so those samples are sent off for testing, and then the bag is it's automatically, but it's centrifuged twice. The first centrifuge will separate the cellular components, the reds, the whites, and the platelets. You can actually separate them from the plasma. And then the second spin, and then they'll draw off the plasma, so it's what we're watching here. And then they, pardon me, they perform the second spin, and that's when you're going to be able to separate the actual blood components, right? So you're going to have, in the end, you'll have this red blood cell bag that's got all the red cells in it. Then you'll have the actual bag with the product in it, what they call it the freezing bag, and then your third bag has that plasma that you had already drawn off, that had already been separated. Okay. If you use the automation, they've found 90% recovery of all the original mononuclear cells and stem cells, and they do have it in a small amount of plasma. You can never discount the presence of red cells. There's probably always some red cells in there. And remember, this is automated, so they're at a point during the automation, DMSO is added. You only need 5 milliliters of a 50% solution. And you can add that slowly to that last freeze bag. And that, again, remember what DMSO does, it prevents the production of those the crystals of the ice. You want to get close to a 10% DMSO solution, but between 8 and 10. As high, as low as 8 up to 10. That's what we're looking for. And then it's ready for, you can separate them, cut them apart and put them in the freezer. Okay, remember it's a controlled freeze. Again, these are usually automated, so they can control the freeze itself. In some cases, they'll they'll use mechanical freezers to bring the temperature down to where it's safe to then put into liquid nitrogen, so that you don't have that rapid uh, drop. Okay, they use a freezer called the bioarchive system, and it's a controlled rate freezer. Again, automated. You can record the freezing curve. You know every temperature it was at every moment in the process. And then they do go into liquid nitrogen. It's actually the units are moved from the bioarchive, and they go into liquid nitrogen. It's part of the process. The QC that we do on this, we still have to do it. You know, comes from a baby, but it's still a product. You know, just because babies are innocent doesn't mean that the cells they produce are any different, more of a problem than anything else. Okay, so we need to assure the adequacy of the product that's produced, and so we perform QC when they receive that specimen where we drew off those tubes before the processing occurs. Again, you're going to do a total nucleated cell count. You're going to do a hematocrit. You're going to do an ABO and an RH type. And you're going to do a CD34 positive cell count as well as a CFU assay, remember colony forming unit assay, and viability studies. Okay. You do have to do a sterility testing and HLA typing as well, which is the point of the bank. Okay, so the especially if this is a public bank, if this is a public bank, these are going to be stored, so you have a higher level of QC. It's not like you're going to put this in and hope that the cultures come out negative. You have a higher level of or expectation of a quality product. And of course, HLA typing, ABO typing, those are of course required. You want to know how to label your unit. So if it is for an allogenic transplant, it's required that you type for class 1 and class 2, including the HLA A, B, and DRB1 loci. Those are the minimum. Those are the ones that cause the most trouble, if you remember, okay? And you also are required to store segments, cryopreserved segments that can have all of those tests done again after thawing, but before use to ensure the integrity of the specimen. So the unit itself, you cut off those segs and you have them, you can use those for the quick testing in the laboratory. Shipping can generally be done within 24 hours of an order. However, it does require specialized containers that can resist, that has to have an outer layer that can be leak-proof. It's leak-proof, and it'll resist breakage, as well as withstanding pressure changes, because obviously there's going to potentially be some air flight in this, and withstand falls. So you want to have an inner and an outer container. That way, if there is leakage, it's still maintained by the outer container. And you also should have it in a plastic resealable bag with absorbent material contained inside, in the event of a leak or a break. So that's pretty much standard stuff for shipping anything that's you know, biohazard. That's kind of what we have to do. You can also ship it already preserved. It's actually preferred that you ship it preferred. You could thaw it at the site and ship it, but it's actually preferred that you ship it in a cryo state. And you can do that in liquid nitrogen. The requirements are that these are the shippers actually have to have QC built in. So the shippers that you use must be able to, the boxes have to be able to maintain temperatures colder than -150 for at least 48 hours past the time of the delivery to the transplant facility. So what we're saying is, if I know that this is going to take a full day to get from my institution to the other institution, the container that I ship it in has to be able to maintain at least -150 for 3 days. That's how you figure that out, okay? And then, of course, to be fully effective, the it usually has to be charged with liquid nitrogen, and you should do that 24 hours before the timer release to make sure that the liquid nitrogen has achieved the temperature in that space. If you've got liquid nitrogen in your container, that's probably going to require a specialized shipper. They have to have a special license for that. You're also required to have a means of monitoring the temperature during shipment. So there's got to be a way for you to say that the temperature never exceeded X or went under is usually not a problem, but it never exceeded something. Okay. The container has to include the name and address of the shipping and receiving institutions. It has to say that it's a medical specimen, and it has to say do not X-ray. That's for if it goes through airport. It has to have biohazard labels on it and follow all other government regs for both states, any states that you're shipping it in. And then finally, thawing and infusion. Again, usually place this inside a zippered bag and submerge it in a 37-degree water bath. Usually you can do this, bring it up to 37 with it in it. It's a little bit more gentle to do it that way. And you're going to need it to thaw it out, okay? You don't want to go too fast. You're not going to put this under hot water kind of thing. If you remember, you have it in the overwrap, the zippered overlap bag, and a little Ziploc, but of course a clean one. And if you discover a leak, you gotta notify the physicians. You gotta notify everybody and prevent further leakage as much as possible. And then aseptically transfer the rescued material to another bag under aseptic conditions and under the safety cabinet, okay? You are gonna wash the unit. Again, you gotta remove the DMSO as much as possible. And you're gonna centrifuge. You're going to determine, you're going to use the volume to determine, you're going to use a scale to determine the volume, but obviously it has to be a precision scale. And what you're going to look for is a volume measuring 1/2 of the unit volume of both 10%, what you're going to use to do this wash, right, to wash off the thing, you're going to use a volume. It's got half dextran, half the human serum albumin, and you're going to add that to the bag as your wash mechanism, okay? Then you're going to basically allow it to sit for a minute and things equilibrate. This isn't like you're going to shake it around. Then centrifuge and express the supernatant into a second labeled bag. And you're going to repeat that, okay? At least 2 washes before you move it on to be ready to drip. Again, your final suspension fluid is 50-50, 10% dextran. I'm sorry, not 50-50. 50 mils, 10% dextran, 50 mils, 5% HAS. You're going to infuse this with an IV drip or potentially a push into the central line. You may require a filter in your institution, but you're not going to use a leukocyte filter because that would be silly. But then you're going to also flush the unit bag at the end with saline in order to get as many cells out of that bag as possible. Okay. There's an awful lot less DMSO in this product, although you can see similar side effects that you would see with any other transfusion. Of course, there could be allergic, hemolytic, febrile, if there could be microbial contamination, and then of the DMSO. It is a lot less common because we use so much less DMSO with this product than with the others. Remember, you could wash the cells as much as you want. The DMSO is able to penetrate the membrane, so it's actually inside the cells. You're going to get some. That's the reality, okay?